the afternoon, we will have Cadaver.
Yes. And light surgery at 12, and we should try to speed up.
Okay. Very good morning, everybody. We are a bit late, but we can easily close the gap. In this day, we will have some lectures first, then we will have a live surgery. Dr. Joachim Ortel will be the surgeon. And we will have, in the afternoon, a hands-on cadaver lab. So then we will have case discussion and finish. In the morning, the first session is the osteoporosis session, and Onur Yaman will talk on the osteoporotic spine fractures, decompression, and fusion indications and techniques.
Good morning to everyone. My topic is osteoporotic spine fractures, decompression, fusion indications and techniques. I will talk about the indications, techniques, fusion levels, pedicle screw diameters, type of the pedicle screws, and augmentation. So there is a good classification about the osteoporotic fractures. This study has been published by a German study group. According to this classification, there are five types of osteoporotic fractures. The first one is a stable injury, and there is only an edema on the vertebral body. On type 2, there is only one fracture at one end plate, and there is a little deformation on the posterior wall of the vertebra. It's again a stable fracture. In type 3, again, there is only one end plate damage, but the posterior damage is more than type 2. It may be an unstable fracture. In type 4, there are 3 types. In the first one, there is damage on both end plates. In the second one, there is a collapse on the vertebral body. And in the third one, there is a pincer type fracture here. They are unstable fractures. In type 5, there is a destruction and also rotation. There is a damage on the anterior part, and also there is a damage on the posterior part, especially in the ligamentous complex. This is an unstable fracture. The same group has published recommendations about these fractures. So they have a scoring system here. They have, based on the fracture classification type, on bone mineral density, pain, neurological deficit. They sum of them, and if all the scores is greater than 6, they recommend surgery. So type 1 and type 2 are unstable. You don't need any surgery. In type 3, you may need surgery. You have 2 choices. The first one is posterior instrumentation with augmentation on the fractured vertebra, and the other one is only augmentation on the fractured vertebra. In type 4, you have 2 choices here. The first one is you can use a posterior instrumentation here, or a short instrumentation with an augmentation in the fractured vertebra. In this collapsed vertebra, you may need an anterior device. And in pincer type fractures, you need anterior and posterior surgery. In type 5, you need, again, a surgery, posterior instrumentation, or posterior short instrumentation with an anterior support on the anterior part. So another controversial part is the fixation levels. So in osteoporotic fractures, if you talk about the long segment instrumentation, it means at least 2 segments above, 2 segments below. And another part is if you have a fracture at the thoracolumbar junction, you have to pass that part. So we have to talk about the diameters. We know to strength, the pull-out strength, you have to increase the diameter, and also you have to increase the length of the screw, but it doesn't work on osteoporosis fractures. You have to need an augmentation there to strengthen the osteoporotic vertebra. So in the literature, there are types of screws, cylindric and conical shaped screws. So in this study, there are no difference between the cylindric and conical shape, but there's a difference if you augment the vertebra. The augmented screws are more stronger than the non-augmented screws. So we use cannulated screws here. This is our paper we have published in 2015. We have produced different types of screws. The types were one pole on one side, double pole on one side, and three pole on one side, and we put the poles on the other side, 1, 2, and 3 poles, and we have seen that we use it on polyurethane materials, polyurethane 10 and polyurethane 14. It means it's osteoporotic bone and a normal bone, and we have seen that the 3 poles on one side was the strongest one. If you use the bilateral 3 poles, you can inject more cement inside, but because of the biomechanical effects, the screws are getting loosened. It gets very easily, the pull-out strength gets decreased. Another study that has been done on AO type A fractures. They have used again cannulated screws, and they have mentioned that they can easily treat that patient at the thoracolumbar junction with short fixation. In this study, they recommend an intermediate screw. Intermediate screw, you put a screw on the fractured vertebra here. It strengthens your system. A problem in these kind of cannulated screws are the cement leakage. In some series, there are 70% cement leakage, but they don't have any symptoms. Another study, another technique that you can use for augmentation is mounting system. It means you prepare your polymethylic acid and you just surround on the screw. In this technique, you have to make a tip like that. I have tried it in few cases. It works, but the disadvantage of this technique is the amount of the cement that you're applying in the vertebral body is less. So in their conclusion part, they say that you put cement inside, but the amount of the cement is less. There are 3 types of applying cement. The first one is direct injection. The other one is the cannulated, and the third one is the mounting type. In the direct augmentation technique, you just insert your cement into fracture vertebra. The advantage is you can apply more cement, but the disadvantage, you may have more cement leakage. The cannulated screws advantage is it's more safe, but the amount of the cement that you're inserting inside is less. So you may use this technique. So another controversial part is the cement volume. There are lots of papers. They say that 1.5 milliliter cement is enough. And the biomechanical studies show that if you apply more than 2.8 cc, there is no advantage to put more cement. Disadvantage, you may have more leakage. So we summarized all these papers and we have published this, all this knowledges, and we have published it with a WFNS spine recommendation with Zilali and Salman Sharif. So I'd like to invite you to the 6th Congress of Middle East Spine Society that's going to be held in Istanbul in September 2022. Thank you so much.
We will have questions after the second talk. And I now invite Francesco Costa to give a osteoporotic spine fractures, vertebral augmentation.
No, type C.
In the meantime, I want to thank you, Salman Sharif and Mehmet Zileli, for the invitation of this meeting. And let's work.
Copy to USB.
Yeah. Okay. One moment, sorry. Thank you very much, and sorry for the delay for the technical problem. We have seen before osteoporotic fracture may be treated by a fixation, but there is some type of osteoporotic vertebral fracture that can be treated also with some vertebral augmentation. This is my disclosure. I don't have a disclosure on this topic. Regarding the indication of vertebral augmentation technique in osteoporotic fracture, the main surgical aim for this procedure is pain relief, improvement of quality of life. We have to think that usually we see older patients, so quality of life and mobilization are a key point in the treatment of this kind of patients. Biomechanical stabilization, prevention of kyphotic deformity, this is a very important point, and a reduction of complication correlated to the conservative treatment. As I said, an osteoporotic fracture may transform and cause kyphotic deformity that in the long-term time can cause an alteration of the sagittal balance, so giving to the patient more problem. So also the prevention and a good timing for treatment is essential in this kind of patients. How it's work in the pain relief, the vertebral augmentation is not very clear, the mechanism. There is three main possible mechanisms that have been proposed. The first is the mechanical stabilization effect of the cement, the thermal destruction of the nerve endings due to the high temperature of the cement, and the chemical destruction, but none of these mechanisms are proven right now. But what kind of osteoporotic fracture are suitable for vertebral augmentation? We have seen before by Honor this paper where they propose a classification of the vertebral osteoporotic vertebral indication. The type 1 that are stable fracture may be treated with augmentation. It's not the treatment of choice, but is an alternative, is an opportunity. The same thing is for osteoporotic fracture type 2. Again, is a stable fracture, so augmentation technique may be an option, but again, are not the option of choice. Finally, the osteoporotic fracture 3, there is for mobile patients without ongoing fracture process, may be treated with augmentation technique. So there is not a clear indication where vertebroplasty or kyphoplastic must be done, but have an opportunity of treatment for this kind of fracture. Another topic that is very important is the timing. When is indicated to propose to the patient this kind of surgical technique? There is some different data and literature, and again, the main conclusion is that these techniques are effective if the patient is treated before 6 weeks from the ongoing fracture. And another similar paper says that the better results are obtained if treatment is performed before 7 weeks, while in the group of patients where the fracture were treated later on, the results are suboptimal. Also because we have to think about the natural history of the osteoporotic fracture, that because the healing process will accomplish in 2 to 3 months. So for the pain relief, is essential to treat with augmentation technique in the early stage of the phases in order to obtain the best aim of pain relief and optimization of the quality of the life. There is really a lot of trials that certificate that vertebroplastic is effective in pain control, but we have to think that there is some risk that amount overall for 1/4 of the patient. So we have to balance about the timing, type of the fracture, type of the patient before to give an indication. In this Cochrane revision, they compare all the studies analyzing the effect in the short term in the first 2 weeks, and in the long term, more than 1 month. And comparing with the conservative and the vertebroplastic group, you can see that the better results are mainly in the short term. So in the medium and long term, the results are quite equal, also because the healing process goes on independently by the augmentation technique. And again, the conclusion is that there is no clinically important benefits in the medium and long term. But when we speak about vertebral augmentation, we are speaking about a different type of procedure, going from the vertebroplasty to kyphoplastic, and there is different tools available. And Onur said before that there is also the percutaneous screw that can be used with the cement augmentation. Regarding the vertebroplastic, is a percutaneous procedure where 1 or 2 trocar is inserted in the pedicle to the fluoroscopy control in order to get the cement inside the vertebral body. Again, here are some data of the results. This study compared the unilateral to bilateral access, and there is no statistical difference in pain control if you perform monolateral or bilateral access, but there is the only statistical difference is that with the bilateral approach, you have more time of a procedure and more X-ray exposition for the surgeon and for the patients. Here are some imaging just to proceed. It's essential to have a good quality of imaging in order to reach the pedicle for the insertion of the needle inside the pedicle and inside the vertebral body, then to release and control under fluoroscopy the progressive release of the cement in order to fill the fracture. But the vertebroplastic have no role to restore the eventual deformity. This is why are mainly indicated in minor deformity and to prevent the evolution of the deformity. The kyphoplastic, the technique are similar to the vertebroplastic, but the difference is that there is a system that allow the restoration of the head of the vertebral body, then filling with the cement, they maintain the restoration of the head and the restoration of the sagittal balance. Obviously, this is a conceptual indication, but timing is essential to define the ability of this technique to restore the fracture height. And there is many different procedures, just to show that there is not only one technique, and just to show that in literature, all these kyphoplastic system are compared, and finally there is no difference in clinical and radiological outcome and adverse event. Probably the spine jack system is the best in order to correct the kyphotic angle, but there is no study that randomized study that compare with the same timing. So this indication must be careful handled. And again, the radiological outcome are almost similar, and as the same, the control trial said that the results in short term and long term are quite similar for all the procedure. Again, some paper that said that with the kyphoplastic there is a correction of kyphotic deformity, but there is no many difference about the long term within vertebroplastic and kyphoplastic. So considering the cost of the kyphoplastic and the overall results, the author of this paper said that with the vertebroplastic is to prefer, especially consider the cost of the procedure. What are the adverse effects, the risk of this procedure? Is well defined that there is the risk of new adjacent level fracture. This is mainly due to the disease, the general disease that is the osteoporotic. having a vertebral body that is correct with the cement, the load transfer to the adjacent level is higher, so there is an high incidence of a new fracture. But there is no significant difference among the different type of augmentation technique. So are all almost the same. The cement leakage is a second main risk. This is obvious, a tremendous case. Usually the leakage may be in a safer space, in an anterior lateral or in the disc space, not in the canal, but it may be happen. We have to keep in mind when we give indication about this risk. And main complication is the embolization of the cement. The vessel embolization is quite common, but sometimes the patient can have also pulmonary embolism of cement. Usually are not clinical relevant, but in some cases the patient can have some problem. And again, there is no significant difference between the different type of the procedure, so we have to keep in mind. Regarding the technique of augmentation for the screw, Honor have described before very well, so I can skip this part. Just to remember that the WFNS Spine Committee have published the work are almost all accepted, so will be soon available on the web and also on the website of the WFNS for the recommendation of all the history and treatment and from conservative to surgical treatment in the website of the WFNS. Thank you very much.
Thank you. Now we can discuss the two talks on osteoporotic fractures. Yes, probably our Dr. Shahzad Shamim can make some discussion.
So both talks were excellent. Thank you, Francisco, and thank you, Ona. Ona talked about the classification and it simplified it really well for us, and talked about the differences in the augmentation process. So you can inject directly into the vertebral bodies through kyphoplasty or vertebroplasty, or you can augment the screws, and there are many ways to do it. And I was particularly impressed with the coating technique that you described for the screws. I haven't used that. And then the different types of pores, unilateral or bilateral. And then Francisco talked about the difference between vertebroplasty and kyphoplasty, and short-term and long-term results in maintaining lordosis and pain relief. If there are any questions from the audience.
I'm Dr. Gusha from Moscow. I'm in frame of discussion. I have one practical question to both of the lecturer. I mean, we all know that sometimes during the surgery, you couldn't predict the osteoporotic situation suddenly existing in operation. I mean, that we all know that's densitometry, which you perform, and it's lateral densitometry, and you have the common density of lateral mass, pedicular, and finally, you have the normal density, and in surgery, you have the osteoporotic of the body. So my question is the following. If you suddenly will see the osteoporosis of body and your screws is not exactly positioned and you have some trembling regarding the future, what are you doing? Just first question to you and then probably Toman.
If during surgery, so it's not a surgery for osteoporotic fracture, but we have to manage osteoporotic bone for a spinal fusion. And during the preparing the drilling of the pedicle and the screw, the sensation is of weak bone. I think the augmentation technique, the change of the screw, the diameter and the length of the screw are essential to try to prevent the risk of the failure of the system. And again, you have to think about all the information that you have to keep in mind when you treat a fracture. It's not a fracture, so the biomechanical aspects are a little bit different, but you have to think the screw like in a fracture technique. So in my daily practice, usually I try to use the screw with a higher diameter, with a more longer, and cannulate and fenestrate screw, and I will put some cement in order to have an augmentation like the slide that I show. But it depends. If you don't have that kind of screw, you can just, after the drilling of the pedicle, perform a vertebroplasty, then put your screw in the cement. Still is not consolidated, and that's work quite well. But it depends also of the facilities that we have. I don't know if Honor want.
It's really nice to have off-the-shelf augmented screws. So whenever you need, you feel intraoperatively that the bone is not strong enough, you have augmented screws available in your center. But if it's not possible, then these are the good options: bigger diameter screws, longer screws, and if nothing else, you can just instead of short segment, you can do a longer segment fixation. That will also work. The other thing that people do is keep the patient in the brace for longer than usual if you're worried about the density of the bone.
You know, I do something else. I finish the surgery and make a vertebroplasty, inject cement around the screws after finishing the surgery. Yes, very easy and more safe.
But that's another point.
How do you inject cement in the vertebral body?
In the vertebral body or around the screws by a paravertebral injection, not through pedicle. Afterwards.
What is the behavior of bone graft in these osteoporotic bones? How? Yes. Yes, if you put the bone graft, how does it behave?
Bone grafts will not be enough because those patients, elderly osteoporotic patients, will have longer fusion times, and immediate load-bearing capacity cannot be provided with a bone graft. Although, yeah, it is a good option.
And I'm going to tell a new different thing, what we are doing now, especially in not trauma cases, like ankylosing spondylitis cases. The bone is too weak. We just insert the screws and we wait 3 months. We don't do the surgery. We put it and we wait for the yes, before put the rods and make yes. So there is an integration there, so that you need a pedicle substruction osteotomy or pontiostiotomies. So you need 2 surgeries. Maybe you can put it with percutaneously.
Yeah.
So you can wait 3 months later. You can do the final surgery.
Alternative to that would be, I have now, I'm sure probably be available anywhere now. It's not something this new. I have hydroxyapatite coated screws, which the surface is a bit rough and the diameter is a bit bigger. So you can use bigger diameter, you can use longer screws. If I don't need to augment, I can go by cortical. And I have good results with that. It's not very much. Yeah. I don't need to augment like that. And, no complications.
One critical question: if you have seen a osteoporotic fracture, a fresh fracture, the patient says, "I have back pain for about 1 week." Do you always make a vertebroplasty?
No, not always. I think there is many factors that you have to consider: the age, the comorbidities of the patient, the type of quality of life that the patient has.
75 years old lady with such a fracture one week before.
In 1 week, I think is the best indication, because we obtain the best results in the short term. So we can provide to the patient the best results of the technique. I don't like at all, because it depends mainly from all the quality of the bone, because the risk there are. If you have to speak with the patient, I will speak to the patient and I propose it.
Thank you. What do you think?
Do you recommend the start of parathormone analog before surgery or after surgery? Like Fostio and all these things?
Medical treatment.
Parathormone, hormone therapy.
Yeah. Well, all of these patients will have to be referred for fracture liaison service and have to be investigated and managed for osteoporosis. Unless you treat the osteoporosis, this fracture will either not heal or patient will come back with other fractures.
Okay. I must tell you, we did a recommendation study, and then we don't recommend early vertebroplasty to all cases. We can apply conservative therapies. If it doesn't work, it's an option. But there is no good evidence in the literature that vertebroplasty is better than conservative therapy. There is no good evidence.
Actually, there is evidence that if you just put in a needle and take it out, versus you put a needle and inject a cement, there is no difference. So you just, so that's a sham study that's already done that has shown this, that there is no difference. The pain threshold is same, the outcome is same, everything is same. And this is 2 years follow-up. So
It's one of the most controversial spine studies ever.
Yeah. And then I want to stress only that practically many surgeons are trying to make a vertebroplasty if they see any compression, any osteoporotic compression. And they think in their minds that if they don't do it in the future, they will cause neurologic deficits or kyphosis development. This is correctly untrue. This is completely untrue. It never happens. Especially in osteoporotic fractures, a neurologic deficit is rarely happening, very rarely. Okay, I think we must stop here. Thank you. Thank you a lot for discussion. Now a case will be presented by Dr. Saad Akhtar Khan. He's here. Good.
Thank you, everyone. Thank you for the opportunity. I hope you guys are all enjoying the heat in Karachi. So my name is Dr. Saad Akhtar Khan, and I'll be presenting a case. This is a case that I recently saw and has not been operated. This was a 60-year-old male, known case of diabetic, who presented with low back pain since last 2 years. The pain has worsened over the last 2 months, and there has been pain in the right leg that radiates till ankle for the last 2 months. The examination overall, patient had EHL of 4/5. Rest of the examination was normal. SLR was restricted in both legs. The right leg pain was more than the left leg pain. The back pain and leg pain was severe was similar in intensity. So these were the Xrays that were done when she could stand. Unfortunately, we do not have dynamic Xrays, but these are standing Xrays, and you can see abnormal curvature in both sagittal and axial planes with decreased disc space at L4-5 and L5-S1. So these were the MRIs. You can see an inferiorly migrated disc segment L4, L5 with some with degenerative changes. Sagittal views. And these were the axial views at L4, L5, showing facet hypertrophy, ligamentum flavum hypertrophy, central disc. And this was the inferiorly migrated disc segment. So roughly 70 male, diabetic, 2 years of back pain, worsened from the last 2 months, could not stand now because of the right leg pain, has weakness in EHL. So, what do you guys suggest? I mean, do you just decompress considering this is a 75-year-old male, or you go on or fix as well?
Yeah, good question. Yeah. Can you please come to the first complaints of the patient? Yes.
So back
Stay
pain?
here. Low back pain for 2 years
Worsened.
and radiating to right leg till ankle.
And the back pain is a similar leg pain.
What about neurogenic claudication?
Sorry?
Neurogenic.
Yes, the patient has not been able to walk now because of the pain, but previously the walking distance was somewhere around 6-7 minutes because of the claudication.
Yeah, let's ask the participants what do you think?
As the patient has now complaint of the left leg pain and there is the external langus weakness, so I will go just for the decompression at the level without fixation.
And what will you say about the fate of low back pain?
The family ask you, will the back pain improve if you just decompress?
Yes.
No, leg pain will improve with the decompression, back pain.
What is your
may not.
suggestion for back pain?
As there is basically lordosis, scoliotic curve is there. So fixation with fusion at this point may improve my back pain. But the newer complaint is just the leg pain. I will go for just the decompression for the root at this time.
Just the compression, and then you don't promise anything for back pain. Or will you do something else? Difficult question, but
Yes.
they ask you always difficult questions. Do you guarantee this is the surgery, doctor?
No, for back pain, there is no guarantee. It may improve and it may not improve.
Yeah. Yeah, what do you think?
In this age, can I see the MRI again?
Yeah. So these are the axial views, inferiorly migrated segment L4-5.
I can't see Modic changes in the end plates. There is a disc.
So this is the inferiorly migrated segment on the right side.
Yes.
I believe there is a crucial question before deciding the surgery or type of surgery. Which pain is more severe, back pain or leg pain? They have similar intensity?
Yeah, similar. Yeah. The back pain is as worse as the leg pain.
Okay. Yes.
No, we don't, because
No.
the patient cannot stand now, has difficulty stand because of the pain, and these were standing X-ray. These were the only standing X-rays that were there. 3-4 months old. I mean, when a month old. It is, sir, because these are standing X-rays, and
Then if disc height is decreased on standing, then maybe one should go for fixation as well.
Yeah. Okay, probably actually, if you can read our recommendations on those items, you'll see that we will try first conservative therapies, then injections. For instance, this patient may benefit from facet injections or epidural injections. If they provide satisfactory pain relief, we will do nothing. Actually, this patient has some spine stenosis, but additionally disc herniation going downward.
Sorry,
on the MR, some disc herniation. Yes. Okay, what did you do?
I've not yet operated on. I just saw this.
You
patient.
you didn't operate yet.
So what do you guys suggest?
Yeah. My suggestion is to make some injections. If it doesn't work, then we can make a surgery.
But the patient already has weakness in AHL.
Weakness is for 4 out of 5.
So EHL extensor Lucis longus is 4/5 in the right side. He's not moving.
But he doesn't complain from the leg pain much. He says it's same.
I agree with Mehmet. I will probably start with injection first. What?
And you see this side. Can you go back on the temperature?
Yeah. Yeah. So. Yeah.
He cannot walk.
I will still give injection because this patient will. Okay. I've seen a lot of discs which will be like that. I will show you a case when there was a big disc. It was intradural extension of that disc, and 3 months later it was gone. So I will still. This guy is. That's 60-year-old.
Do you think it's going to disappear?
So it is chance. There is a chance that this patient after the injection will start working again. So then the injection will have also diagnostic value. So I will go with bilateral. I will go. It's 4 out of 5.
Weakness is minor.
This could be pain-related weakness.
Can relieve by the time.
I just wanna say something. So I will start with bilateral facet joint and bilateral nerve root injection. I'll block that level completely, and I'll see what happens. Because like that, I will block also the back pain.
First of all, we have to learn to get scoliosis graph, okay? If you look just.
You can close it.
Ortel, are you laughing to me or?
Thank you.
Look,
Thanks a lot.
look, because, no, look, Ortel. If you look just on the lumbar X-rays, okay? Sorry, can you put the X-ray? Hocam, bir X-ray görebilir miyiz?
We are changing.
Only a few words.
You can tell.
If you just look at the elephant's legs, you will fail, okay? The cause of the pain on the left
This
side,
one.
Ortel,
Yes.
Ortel.
No.
The cause of the pain on the left side is because it's in the concave side. The nerve is compressing there, okay? If you don't see the scoliosis graph,
Yes.
the cause of the pain on the left side is because it's on the concave side. It's compressing on the nerve root, okay? So you have to do the surgery. You have to decompress that level to decide which level. Is it type 1, 2, or 3, according to Berriano or Lamartine classification? This one is non-apical one. If you do just L4 and L5 with decompression and fusion, you can solve that patient. Okay.
There is likelihood that this patient will end up having fusion because that is very high.
Yeah.
But actually, we must stay as much conservative as possible.
Yeah.
A fusion surgery's complication rate is about 20–25%. If we tell them fusion surgery, then we must also tell them the complications.
Well, in my opinion, first, the case is not a good case for stenosis. It's a
right.
disc. It's a disc with maybe instability. You know, this scoliosis is old. I think we don't have to treat scoliosis per se, but the thing is that the increasing pain for the last 2 months might point out to some instability, which causes at the end the disc prolapse. So I doubt that this patient is going to be successfully treated without surgery. And if the patient is in bed and complains, so you can put him on IV medication or maybe some injection, but if after a week, if it's not good, you have to proceed. You cannot leave him in bed. You have to admit this patient, put them under some observation, and then you proceed. And what we do, we usually decompress, and then if we see some instability, this patient will give written consent that you can proceed with stabilization on the same procedure.
Thank you, Joachim. Since we are late on the program,
You don't agree?
No, I agree. Look, we are talking the same thing. If you have to do an X-ray with scoliosis graph, the scoliosis, you don't have to treat the scoliosis. It's type 1. It's not the apical part. So it's non-apical. So if you just do L4-5 decompression and fusion, you will solve the problem.
And worsen the patient's neurology.
no, never. No, simply no. I will talk about those subjects now, our recommendations. I will give a lecture on about this. Thank you for good discussion. Actually, we cannot reach a good consensus every time, but these are very fruitful discussion. Now I will, since one person is lacking here, I'm covering his talk. It was on the lumbar spine stenosis, decompression only. But so then I will try to limit my talk to decompression only. We did previously, we did a lumbar spine consensus conference. As some of you have observed us here on the back pain and lumbar disc herniation yesterday. It was 2 workshops. One was in 2018, then the other one is 2019. And we used Delphi method, and we did a voting system. And we had 6 panels. And at the end of those 6 panels, we created 6 publications. You can read them on the special issue of World Neurosurgery. This is the papers, 6 papers. The natural history, if you don't touch a lumbar spinal stenosis, 1/3 will spontaneously worsen. 1/3 will improve with conservative measures, and the remaining will stay stagnant. There are some predictive symptoms on the radiology and also like presence of radicular symptoms and back pain, presence of degenerative listhesis and scoliosis, and illness duration more than 1 year, that we can predict they will worsen. If these things we see, we can make more aggressive treatments. One important thing we must never forget, that there is no good correlation between clinical symptoms and the radiology. We always forget it. We actually, for decision making of this previous patient, we must look at what the symptoms are. If the patient has said, I have more back pain than leg pain, we would never operate that patient. I'm totally disagree with any surgery. But if he had said leg pain is more prominent, then we could make a decompressive surgery only. Another thing is the instability criteria in the radiology. Modic changes are important. Discal vacuum phenomenon, traction spurs, synovial cysts, annular tears, presence of spondylolisthesis and facet fluid sign. You can see here a nice example on one side, especially facet fluid sign. Neurophysiology, EMG or evoked potentials, unfortunately, do not give us any good evidence or decision making. Do not predict outcomes. So then there is no place of electrophysiology. Electrophysiology may be necessary if you suspect other diseases, polyneuropathy, ALS, or other diseases. What about treatment options? Non-operative treatments. Yes, epidural injections, physical therapy, non-steroidal anti-inflammatory drugs, lifestyle modification, exercise, and weight reduction. I can skip more quickly. There is no consensus if some factors help us to advise conservative treatment and the type of conservative treatment. And there is no consensus if 3 or more months of conservative treatment should be applied before surgery. But anyway, we, before starting advising a surgery, we can still talk about the conservative option because many patients may benefit from conservative treatment. What are the injections? Injections are facet joint injections, epidural injections, and sometimes root injections. Surgical treatment, decompression is the basis of surgical treatment of lumbar spine stenosis. Even you make a fusion surgery, you must add also a decompressive surgery. Fusion is an optional, especially when listhesis or instability are present, but indications remain still controversial. What type of decompressive surgery may be done? There is no consensus whether microscopic techniques are equal to standard laminectomy to achieve adequate spinal canal decompression. The outcomes of minimally invasive surgery, the long-term outcomes, are not much different than open decompressions. We used to do total laminectomies in the past, but since if you make a total laminectomy, if you remove facets, then you can create a iatrogenic instability. Because of that, we then started fenestrations, and a recent trend is to use a unilateral approach and bilateral decompression to protect ligaments and a part of the lamina. So this is the technique. You can make this with a tube-guided surgery or a microscopic surgery with hemilaminectomy retractors, or sometimes even some endoscopic surgeons are doing this, although it is more troublesome and then more time-consuming thing. In general saying, however, MIS surgeries are associated with lower complication rates, especially infection rate is quite lower than open surgeries. It's well known. I'm a fan of tube-guided surgery. I do routinely that. I started with using endoscope, then switched to microscope. And these are some films, pre-op and post-op films of one patient, 2 levels decompression with a tube-guided surgery. And this is even for 4 levels, you can make it from L1-2 to L4-5. These are the incisions. And this is on the left axial, this is the pre-op, and right axial post-op films. Surgical complications are very low. Incidental durotomy is the most common complication probably. It may be almost 10%. And especially in the learning curve, you can have more dural lacerations. But then by the time if you gain experience, the dural laceration will diminish. I will stop here because fusion surgery, the indications and techniques will be told by Dr. Artem Gushka. Thank you.
Thank you, Mehmet. I'm very happy to be here. It's my really pleasure, and I thank you for invitation. Special thanks for the Professor Salman Sharif for this magic fairy tale tour to the mountain. Thank you, Salman. Thank you, your team. It's really hard work. Imad, it was really, I think, the very impressive tour in my life. So thank you. Hope it will be repeated again somewhere. We have another 2 weeks tour, I know, to the another 8,000 mountain. So as was announced, I would like to share my experience in the treatment of lumbar spinal stenosis with fusion. And it was told by Professor Zeleli, we all based on the guidelines which was published by WFNS Spinal Committee in guidelines, and it's well-known proportion of the methods which start from the non-surgical conservative treatment, then go to the surgical treatment with minimal invasive possibility, and then with fusion. But I also would like to speak about mostly minimal invasive characteristic and fusion and decompression surgery for lumbar spinal stenosis, as it's mostly the most preferable and very attractive alternative of the open surgery. So we all know that the decompression could be performed directly or indirectly from lateral part, or it can be done with mini anterior or X-leaf direction. I wouldn't be concentrated on some exotic part of the decompression and fusion for the stenosis, and we'll speak mostly about, let's say, traditional approaching. So I also perform treatment of lumbar spine stenosis using mini open posterior lumbar interbody fusion and surgery, and perform mostly transpedicular interbody fusion, but also we have some experience in ALIF and the transforaminal approach and the percutaneous fusion, which mostly attractive and using for last several years. So instrumentation which popular in treatment of lumbar spinal stenosis, it's percutaneous instrumentation. Sometimes we're using mini open instrumentation if it's long or intention to improve scoliotic deformity. But in most standard instrumentation for the limited stenotic compression, we have the indication for the patient with not severe spondylolisthesis, first and second grade, central lumbar spiral stenosis from L2 to S1. We perform this surgery in case of second or third surgery, in case of complication of this surgery, in foraminal stenotic with radiculopathy. In case of pseudoarthrosis or facet syndromes, it's somehow connected with the case which was presented in the beginning. For obese patients, we also sometimes use these techniques. So we all know these operations. The very important thing is location of the approach, and it's always navigated with fluoroscopy. So we're doing the certain lateralization of tube positioning because of it's important to to know which structure you want to have in the end of tube. I mean, it should be some lateralization from 2 to 5, 7 centimeters, depending of weight of the patient. Then we're doing well-known surgery with decompression and with fusion. I would have some video here, but it could be skipped. So then we performing the fusion spondylolisthesis with some cages or bone in implantation, and then percutaneous transpedicular fixation with normal screws depending on the length of the pediculars. So this is the final results of minimally invasive transpedicular lumbar interbody fusion, and this is like this surgery looks in case you are doing one side fusion and both side transpedicular fixation percutaneously. In case of performing minimal open translumbar interbody fusion, this samples is L4, L5. You position the screws based on the navigation of the fluoroscopic guidance, and then you can do the instrumentation via the existing portal navigated tube, and from the another side use just percutaneous screwing as it was recommended by different instrumentation company who performed this this production of these devices. This is stages of the surgery and final result. I want to remind that there are many papers which provide the information that the patients with degenerative stenosis and even not severe spondylolisthesis have better result in the minimal invasive approach than open decompression and instrumentation. And that's why this technology, transpedicular lumbar interbody fusion and percutaneous instrumentation, is recommended for the patient with grade 1 to spondylolisthesis and the not longer 2-3 segments stenosis. And I would like to say also regarding this common question that in comparison of 10 years, the amount of patients in developed countries and in developed countries also is severe rising. I mean, for Russia, we have now nearly 500,000 people who needs to be operated having a spinal stenosis. That's why having this, and we performed the special investigation with our spinal association. That's why, of course, the surgery or stenosis should be somehow modified to the most reliable and fast way, as the amount of the patients so big. That's why we more analyzed not the technology of fusion, but there's some problem which exists in case of we performing this standard approach to the lumbar stenosis surgery. And I would like also to concentrate a little bit on this problem. The first problem which we agree exists after surgery, it's degeneration of the joint level. So according to the big investigation and in analysis of literature, there are about 30% of joint level stenosis, and we personally have always about 20% of patients were returning back after 5 to 10 years with the same problem in the joint level. And it's not only the question of the percutaneous transpedicular fixation, but also some destructible devices, which I don't know, not presented in each country. For example, this destructible screw-free destructible device between, so-called, it's also provide later on the problem for the joint level. Another problem which exists after short instrumentation is so-called proximal junction kyphosis, PJK, because this picture, unfortunately, coming among our patients, especially treated by neurosurgeons, because the neurosurgeons like this short fixation. And finally, this patient with accessible problem with the adjust level after short instrumentation, and avoiding the problem with the sagittal balance losing. And he was operated shortly then after existing of the problem on the adjust level. We have to perform PGK on the upper level and long instrumentation. Finally, he was positioned in a normal way, but it's always the question and always the discussion, and it exists even now in our auditorium, the discussion between neurosurgeons, who is orientated on the so-called neurosurgeons way in the short instrumentation, and orthopedic surgeons, who is performing all kind of way of the instrumentation, and always check the sagittal balance and perform a long fusion and instrumentation in case of losing of sagittal balance for the patients with spinal stenosis. That's why the amount of surgeries and surgical approaches for the different specialties according to this Marx concepts well known in orthopedic surgeons is always have to be checked. So the guidelines, which actually approved by the returning to the question regarding the variance of the fusion and instrumentation in spinal stenosis, the guidelines is quite understandable and not very easy readable, but we know that in case of we have asymptomatic lateral or central stenosis, and it could be some different direct minimal invasive and direct decompression. If the stenosis is connected with instability, or you have to resect the facets more than 2 levels, more than 1 or 2 levels, you have to perform its candidate for the fusion and transpedicular fixation. This guidelines is connected with minimal invasive approach to the spinal stenosis, lumbar spinal stenosis, but very useful to check the most appropriate variants of instrumentation. Of course, we already left the view of the patient, which just I think 10-15 years ago, each patient after stenotic, degenerative stenosis surgery looks like this with drainage. And now we can perform all the procedure via portal navigated, via tube or minimal invasive destructor and percutaneous instrumentation. Even last 3-4 years, there are possibility to perform full endoscopic decompression for lumbar spinal stenosis with instrumentation and fusion. These devices, we are personally using the devices produced by company Joymax, and I'm quite convenient to perform a local 1-level decompression with percutaneous full endoscopic procedure. And to perform fusion with the same tube and percutaneous instrumentation. The understandable question how it's possible to perform decompression with severe stenosis in case of the ligament of flavum, for example, attached to the dura. But the procedure performed via very small tube, and even if you have laceration of dura and small leakage, you never have a problem later on with this patient, because the soft tissue covered this puncture laceration, and we never seen any problem with cyst dural leakage. But 1-level decompression, it's completely enough to perform the adequate nerve restoration, and finally the result is very basic. What I want also to present in this way, there is some new devices we start to use for lumbar spine stenosis, so-called pedicle latening osteotomy, PLO. And it's interesting new technology. It was published in Spine, first one in 2013. Now we have 2 publications, and it's reliable technology for the segment stenosis more than 2 levels. There are also very big and not very easy understandable algorithm for restoration of diameter of spinal canal and deformity correction. And in some cases, we use so-called PLO, posterior lengthening osteotomy. This technology based on the idea that the screws position in pedicular could be latening. So we instruct the screws to via the pedicular to the, as usual, to the body. Then the screws can be latening, and it's provide the increasing area of spinal canal for the 20%, and foramina can be increased to the 50%. So that's quite new. It's also, this result was published in 2 years ago in Spine, and that's interesting, attractive technology. Not could be used in all cases, not traditional, but rather interesting. And having this this possibility, we subdivide surgical options for lumbar stenosis based on the idea of stability, deformity, and pain to the different kind of, it's our, let's say, practicing. Just I want to inform you about variants of surgical approach in case of spinal stenosis. For example, if you have stable L5 S1 2 segments, it's mostly transfemoral lumbar and body fusion with instrumentation. For the more than 2 segments, it's open decompression. Of course, unstable segments, we're doing also fusion, but it's also the place for the lumbar subtractive osteotomy. This here 20% approximately in case if we have stable 1-2 segments. So there are many options on this way, and we can use all of them for this kind of surgery, especially remembering that the patient with lumbar degenerative stenosis, they have a lot of comorbidities, and in each case it should be a special approach. What else? We well known the guidelines also publishing in the special options in lumbar spinal stenosis with high level of evidence. And in this situation, there are recommended different kind of surgeries. And also, I'm not personally a fan of the interspinal devices, but in some situation, if you have the stable 1-2 spondylolisthesis, and there is some limiting of the open surgery situation, and if they are performing one side approach with so-called over-the-top decompression, the instrumental interspinal device is quite attractive, especially because that's for traditional fusion surgery, the complication rate can be quite higher, and having the recommendation published in last book of Professor Michael Meyer, there is recommendation of this destructible interspinal devices for the situation where there is no real spondylolisthesis, more than 15%, and mostly back pain more than leg pain. That could be the reason to use this approach for the stabilization of the spinal stenosis. But in the same time, the last, not even last, in 17 and 2018, there was information that the devices interspinous could be used as a standalone device only in case of considered as off-label used. So that's why the people make some different approach to these constructions. We also have some exotic variants of instrumentation and fusion for a patient with mostly for lumbar spondylolisthesis. It's a little bit different story, but I would like just to demonstrate its axial leaf if anybody will have it. But as for my opinion, it's not our case. Such thing which prominating in the soft tissue, it's rather problematic for the patient. And we have 25 cases 5 years ago performing with this listhesis situation, and finally we also excluded from our practicing. And what we recommend to do, and what is now quite popular, it's some functional instrumentation, and due to we have the device which provide movements in instrumentated segments, we used very often nitinol. It's so-called materials nickel titanium naval ordnance laboratory performed. This is material with memory form, and due to technical properties, this rods can be bent according to the patient length, and then these materials provide some movements approximately to 8 to 10 degrees. That's why it's the real prevention of adjust segment degeneration. That's why in case of one level stenotic, we perform instrumentation with the nitinol rods, and in this way we so-called cover the adjust level of the development of degeneration. I'm going to conclusion. So it's common conclusion regarding lumbar stenosis. There is insufficient evidence for the effectiveness of conservative treatment, of course, for lumbar stenosis. Treatment of lumbar stenosis depend on degree, level, and architecture of the stenotic, severity of the symptoms, and the use of minimal invasive treatment in fusion, decompression, and instrumentation for lumbar stenosis is preferable. Thank you.
Thank you. Really very nice talk. Are there questions? Because we are somewhat late on the program. We can get some discussions. Okay, let's go to coffee break. Thank you.
हाँ, I guess.
लंबा करने के लिए एक्चुअली
Hey, can you please close these lines? Okay, let's start this session. I learned that some speakers are lacking. Please close these lights. They don't know how to close. Okay. This is a 55 years old male with left sciatic pain. But no stenosis, no stenosis. What do you recommend? You are resident? The ladies, you are not resident? Huh? They are residents. Okay. What do you recommend?
How long is the pain?
1 month.
I can see a big fragment over the nerve root, and generally we say up to 6 to 8 weeks of conservative therapy. So maybe a couple of weeks of conservative therapy, and if that fails to improve the leg pain, then I would do small laminotomy and excision of the sequestered fragment.
You want direct X-ray?
Yes, X-ray would be nice.
But how old is the patient?
55. No, but also symptomatically, he didn't say he has any back pain, just leg pain. So it's unlikely that he will have any significant abnormality. Plus the facets joints look acceptable, nothing significantly wrong with it.
If he had no leg pain, what would you do?
Like conservative, then definitely not surgery. If he has no leg pain, no.
Okay. Let's ask you.
Same question.
Yes.
First trial of conservatively treatment
Yeah.
up to 3 months, whether the pain is relieved or not.
3 months?
First trial, 3 months trial should be given to the patient.
For lumbar disc herniation?
Yes.
3 months is quite long.
6 weeks. 6 weeks. No, up to 12, no.
Yeah.
For symptomatic, up to 6 week conservatively treatment should be given. Whether after that, whether the pain is relieved or not. Whether if the pain is conservatively or some weakness is developed, then we should go towards the surgery. If the pain is relieved, then the conservative is.
Let's say the patient has no benefit after 6 weeks and he wants a surgery. What type of surgery would you do?
I will recommend fenestration with the discectomy.
Microdiscectomy.
Yes.
Would you, if you had experience, would you make a endoscopic surgery?
Yes, sir.
Endoscopic surgery?
Yes, sir.
Yes. What type of endoscopy can be done with this?
I have no such experience.
Not exactly.
You don't have experience. Tubular group. Okay. What do the faculty want to say? Do you want to say something?
So what is the evidence with regards to conservative management? So we must know that for acute disc herniations causing radiculopathy or motor weakness, the results with or without surgery at 2 years, the outcome at 2 years are the same. So it doesn't matter if you operate or do not operate, the 2-year outcome are the same for the two, for both conservative and surgical management groups. At 6 weeks, 85% of these patients will have complete resolution of symptoms regardless of the size of the disc. In fact, there are meta-analysis which show that the extruded fragments, the bigger the disc, the more likely it is to resolve, even though the symptoms may be more severe. All right, so the indications for surgery will be pain, not responding to medical management, progressive motor weakness, not fixed motor weakness, not mild 4+ EHL, as Mehmet pointed out in the last case, or Kodak-Warner syndrome. And if these things are not there and the patient is willing to try conservative management, you can give the patient trial for 6 months, 9 months, a year if you have to. You don't have, so 3 months is not a deadline, but yes, if you have to offer surgery, you'll wait at least 6 weeks because 85% of patients will recover within 6 weeks. If I have to offer surgery, I would do a standard microdiscectomy.
Okay. Yeah, Onur.
According to our yesterday's consensus meeting, for acute disc herniations, we can recommend 2 to 14 days bed rest. We can use non-steroids, and according to Christoph, we can use epidural straight injection. This was our consensus statements.
Epidural injection. What do you think?
Well, in the end, it depends on the patient. So if you have a patient without any symptoms, what was the saying just a few moments ago, then of course you just don't do anything. If you have here a patient who has some symptoms like pain and dysesthesia, then you can start with conservative treatment. You do it for 6 weeks, but the 6 weeks I would not fix it completely and as a hard cut. If this is a young patient, young male, for example, who likes to do activity sports or something like that, and he has real disturbance due to these, we would call it minor symptoms, then you can indicate surgery quite earlier than only 6 weeks here. If you go to surgery then 6 weeks after it, or the patient had harder symptoms, then you can do microdiscectomy, like not discectomy, a sequestrectomy from our perspective. Or if you do it in a tubular way, I would probably use more the interlaminar approach, easy go system, for example, and not transforaminal. It's too far medial from my perspective. That's my recommendation.
Yes, one point is that, nice to say that this patient has a free fragment migrated downward, and then not a very good candidate for a transforaminal discectomy. Although very experienced surgeons are making with special type of disc removers, and then by drilling the foramen downward, they can make it. But I believe this is better to do with interlaminar approach, interlaminar full endoscopy or tube-guided surgery. So I can cut here the discussion and then yes, he had no motor deficit, straight leg raising 45 degree and extruded disc herniation. And this is again tube-guided surgery. There are different terms used in discectomies. One is fragmentectomy or sequestrectomy. We discussed yesterday. In case of highly migrated disc herniations, you can remove just that part. So then it is a sequestrectomy. Like you see here, this is a disc. And then you don't enter the disc space. And the results are almost same. And we mentioned yesterday that the amount of disc you removed and the postoperative pain relief has no correlation. So this is finished. This is probably 15, 20 minutes surgery. And then when you remove the tube, the muscles reapproximate. Yes. Oh. What? There is a problem. Yeah, okay. I think it worked. Now, as you know, there are different techniques, minimally invasive different techniques in lumbar discectomies, microdiscectomy, transforaminal endoscopic discectomy, and interlaminar endoscopic discectomy. And it may be different in two ways. One is the microendoscopic discectomy, which I showed you the video, my video. And the full endoscopic thing, the people call it full endoscopy. Why they say it so, I don't know. But it is with water irrigation system. So then the tube diameters with the microendoscopic discectomy is 14, 16, or 18 millimeter. However, with water irrigation system, tube diameter is about 7.5 millimeter. This MED system has been first introduced by Foley and Smith, US surgeons, in 1998. So then they called it matrix system, and they were using, and the main difference is dilatation of the muscles instead of separating them from the lamina and spinous process. In the microdiscectomy, you must separate them. And in the beginning, although the surgeons started with using endoscope at 25-degree tip, then they switched to using microscope. I did the same myself. This is there is a flexible arm attached to the table, and you can further go with endoscope or microscope. These are the parts. Actually, the main advantage of this technique is you use the similar instruments you use in microdiscectomy. But they have to be black coated or non-glaring type of instruments. And you have introducers and a 25-degree tip endoscope. These are some steps from my own patients. Yes, I can skip them. And you remove the ligament, and then you see the fat tissue, then the dura, and retract the root, and then enter this space, or remove the disc herniation only. You can provide two-level surgery with one incision because you can angle your tube. It's possible for especially for 4-5 and 5S1 levels. It's quite easy, and you can also make lumbar spine stenosis by unilateral approach and bilateral decompressions. The incision line is about 1.5 centimeters. This is the one I have shown you. And the far lateral lumbar disc herniation can also be done with the same technique. And this is one of the far laterals. I will show you one. You dock your tube on the edge of lateral part of pars and transverse process. So then you aim on that angle, transverse process and pars. You open the intertransverse ligament and you see the fat tissue. After retracting the fat, you will see the traversing nerve root. Now I'm retracting the nerve root, and just underneath is the disc herniation. Yes, this is nerve root. I retract it. Surgical duration is 30 minutes. Bleeding on probably 5 cc. And this is the big fragment. Yes. I always use irrigation. There was one study yesterday. We talked about the irrigation, the importance of irrigation. You can remove the remnants of the free fragments inside the disc space. So then postoperative recurrence rate is somewhat lower. There are many tubes in the market. Medtronic Matrix tube, Storz EasyGo tube, and the Standu systems. And there are also domestic tubes systems. I think there is a Pakistani company also. And you can also use the same technique for lumbar spine stenosis I mentioned in the previous surgery. And yes, you can see here one video. This time, the tube diameter should better be 16 or 18 millimeters, because you then enter your high-speed drill inside, and irrigation must be done by your assistant. Middle facet should be drilled. It is possible to do that surgery with full endoscopic system. However, you have to use special drill bits for that purpose, and they are very expensive. As I know, one drill bit is about 1,000 euro or something. And then you cannot use them again and again. However, normal Midas Rex drill tips are possible with this technique. You can angulate your view by changing the tube and fixing it to the table. This surgery was 1 hour and 20 minutes, and bleeding was 50 milliliters. Unilateral approach and bilateral decompression for lumbar spine stenosis. Maybe I can go quicker. Doesn't work. Microscope. You can achieve a 3-dimensional view and easier. Yeah. If we as human being are doing surgeries, we are abilities of our body, and we must not force them too much, probably. This is my philosophy, actually. You can do it, but it takes time to get more. Maybe Joachim can make some comments on that. What do you think, Joachim? We use, instead of endoscope, we use microscope. What do you think? Because we are less talented persons.
The problem is, we should do the discussion at the end. Can I do this? The discussion at the end?
Yeah, no, you can make some comments.
Because the problem is, I think it can the endoscope limits. So if you have done 1,000 cases or maybe 500 cases, you feel not comfortable. We have done now 3 different evaluations with our residents. And they all feel better with the endoscope than with the microscope, because the angular view and the magnification, the identification of structures is much easier when you have the endoscope. So that's an interesting finding, because when you have done all these procedures already, you don't mind this. But to use a tube with a microscope, it's much more difficult when you have no idea about using a tube than with an endoscope, because you see all the structures. So it's very interesting. There's always a discussion. Many say that they have no problem with the tube. But when you ask someone who's learning this, it's much more difficult to do the tube with a microscope than do the tube with an endoscope.
Yeah.
So this is conflicting results.
And another thing I had in the beginning, the tip of the endoscope was with the bleeding was repeatedly we have to remove it and clean it up.
We cannot talk about the first metrics system. We could not do endoscope. The endoscope was such a poor quality, we could not see it.
Yeah.
The first system.
Yeah,
So we
it
have
may
to
be,
talk about
yes.
the current system. The current system.
Yeah, there are many aspects of that. Now this is finished, bilateral decompression. I showed you already these slides. And if I compare transforaminal endoscopy with interlaminar, actually indications of transforaminal endoscopy is quite lower than interlaminar endoscopy. And L5S1 is easy with interlaminar. However, with transforaminal, it is quite difficult. This Ruten's technique with water irrigation system that I mentioned to you is this is his photographs of live surgery. And these are the technical details. I don't have any experience with that. But since you don't have a retractor here, your tube must retract the nerve root. So then injuring the dura and nerve root are more possible with this system instead of tube guided systems, especially in the learning period. So then some endoscopic surgeons say that you must start that full endoscope system first with transforaminal endoscopy. Then after gaining experience, you must turn to the interlaminar. Yes, and with such drills, as I mentioned before, it's possible to drill the lamina and enlarge the lamina, even in spinal stenosis. but it's quite time-consuming thing. It's not very easy. So disadvantages: stenosis drilling is harder, steep learning curve, and baseline instruments are expensive. Actually, full endoscopy instrument sets are quite expensive than tube-guided systems. I will finish my talk here, and then yes.
What is the number of participations in Scarbase? Is it higher than here? $21 there, and how many here? No, I mean, I just wanted to point out to you, it's very nice to do brain, but you live from spine. So you have to be here if you want to become rich. Sorry to say so. I do 50-50, but I live from spine. I think this is important, Mark. Okay, so sorry. So next step. Now I show you the what we just discussed with Mehmet's nice videos. I have to disclose that I received some support in the past, not for this meeting today, but for several aspects of this presentation. And I was asked yesterday where I'm from. So this is where I'm from. I always show this picture. And you see here, this is just at the French border. It's Homburg with an O. It's not Hamburg, not the city at the sea. It's close to France here. Strasbourg, Luxembourg, Frankfurt, 1 hour. Oops, this is our department. What happened to my slide? And we do a lot of endoscopic and MIS procedures. Actually, the traditional department, so they fight with Yashagil about the first microdiscectomy. Now almost all involved people are dead, so we will not figure out. Oops, there's automated. This is not wanted. So I will do it like this. However, definitely there was a very early period. The microscope was used for spine in this department, and there's a very innovative department. And the former chairman, he also was editor of the Neurosurgical Acta Neurochirurgica journal in Europe, the ENS journal. So also the CASPA system was developed. I have two, three words about ISMIS, because I'm the ISMIS president. So it's an international society on minimally invention in spinal surgery. The Turkish chapter is very active. This is actually, yeah, beside of us and Zurich, it's the very few active chapters. So I would be happy if I could gain more interest in Pakistan, because you have all these people who are interested in spine. It's quite a traditional society, which is not small. So where is it? These are all the presidents. So I'm the president now for 1 year. And you see here, there's more than 600 members. And it's not specific to endoscopy or something or injection techniques. It's everything which is considered to be less invasive in spine procedures and to have a new aspect. So it's rather a society we think about innovation than on focus on well, randomized studies or something, rather to keep us a little brainstorming on new ideas. There are also some guideline papers, but this is rather difficult, as we have done yesterday, to find guidelines for endoscopy or minimally invasive techniques. So if you're interested, just talk to me, and then we will find a way. Good. So now I come to my talk, interlaminar discectomy. Microsurgery, I did not know that Mehmet will point this out to you, an interlaminar approach. So we have different localizations of sequester. Here's a right behind the L3. Here's a caudally migrated huge sequester. And this usually is approached by interlaminar approach. And well, the interlaminar approach needs, if you use this for many levels, particularly at the disc level, needs a lot of removal of the lamina. So when we know this even from the endoscopic technique, when you use a full endoscopic technique without drilling, you can basically only do the discectomy at L5S1 because all the other spaces are too small. So this resection results in a detachment of ligaments, and well, frequently you are involved in the facet joint here, and then well, this potentially increases the amount of fibrosis. The more you expose of the thecal sac, the larger will be the scarring. This is not very difficult to understand. So for the endoscope, we have very different ideas and approaches, and we will see how good we can do this in the Cadaver lab this afternoon. So we have a transfemoral set. We have actually two, right? Two transfemoral set. We have a spine tip and another one. So Revo spine and spine tip. Then we have and easy go. So if there are three sets. Okay, so anyway, we have a set which is possible to come the transfemoral approach or the extrafemoral disc, and then we have a tube-based test for a tube-based endoscopic procedure. And you see here on the left the early development of the transfemoral and extrafemoral tube system. This was actually Dr. Loy, who was one of the founders of this ISMI society. He used the system until the early 90s. The problem was that you basically had no irrigation, you had no good bipolar coagulation, so you could really only approach a sequester, take it out, and go back. So there are newer techniques. So like this is the Revo spine, or there are other techniques like the spine tip we will see, which we in our hospital we use only for transfemoral. We don't do the interlaminar approach. For the interlaminar, we always use the tube-based system, which I think is much more convenient, and it's because you can use a bimanual manipulation. It's much easier to manipulate. Okay, so here are different other developments. This was the Vogel system, one of the first endoscopic system on the market, used in the mid-90s. It was left because this had to be done on the CAT scan guidance, and then when you had to convert, you went with the patient awake to the OR, and then the patient had to be intubated, and then you have to turn the patient. So it was a very difficult thing if you could not achieve your results. This is a Descendot system, for example. It's the endospine system, which is still on the market. I think it's a good system. It's mainly used in India. I know that in India, minimum 30, 40 surgeons still use it every day. The problem is that you really have to use it every day. Otherwise, because it's with all your movements, you direct with the suction device, your tube. So every time you suck in a corner, your view is different. So you really have to get used to it. It's a little bit more difficult than coming from a microscope and using a fixed set. So this is the metric system. This is the first system which was available with an endoscope. However, the development of the endoscope with the Medtronic was not as good in the beginning. Now they have it again with the endoscope available with a new endoscope, but I cannot tell you anything. I have no experience. Why? Why have I no experience? Because it's not permitted for surgical use in Europe. It's only permitted in the States. Maybe you can buy it here. I have no idea. Should be better the quality, but I don't know how good it is. The old system, impossible to use. You did not see anything. It was like the resolution was the standard definition. So 400,000 pixels, you would not see anything. It's very, very poor resolution. And this is the EasyGo system and spine tip. So there's no consensus about the ideal approach for migrated lumbar disc herniation. However, there is a history of this description of the intralaminar approach. Actually, originally it was described for migrated disc. We use it mainly for non-migrated disc L5S1 and L4-5. When you have a straight approach parallel to the disc space, you have to go translaminar. This, I will show this in the next picture. Okay, so here you see historical images from the Di Lorenzo publication, Soldner publication. There was also a publication from the guy from Hamburg. What's his name? Papavero, I think. He also published on this intralaminar approach as an Italian spine surgeon working in Germany. So now we come to the endoscope. What's the advantage of the endoscope? Well, the advantage of the endoscope is that you can reduce the diameter of the tube. It's not, if you don't feel comfortable with the tube, you should not try it. So if you feel comfortable with the tube, then you can further reduce the diameter of the tube. And then one point you have a diameter of the tube you just cannot use without an endoscope because there's no space. With a microscope, you need space, a corridor for your view. If you don't have this view, you cannot proceed. So this is particularly with the orange tube, with the smallest tube. And well, actually these patients, if you use this and they do a successful procedure with this setting, they have a very little muscle damage and very little post-op pain caused by the approach. Of course, there's no difference in long-term outcome. There's less infection rate, there's faster recovery, and there's better cosmetic results. So you like to have your wife a scar like this and not a huge scar like this. But at the end, after 6 months, it's the same. So these are the potential advantages: small skin incision, minimum muscular trauma, no dissection of ligaments, minimum exposure of the dura, minimum manipulation of neural structures. Another study on this, so this was obviously something which mainly German neurosurgeons, Reulen was from Munich, had in mind. And you see here the thing, why is it as nice to come, for example, for this disc level? Then we try to be perpendicular, straight to the disc level, L5S1. It's written here 4-5, but it's not good. When you have the angulation, then you're right at the lamina. So it's really, it's a nice approach, which is not that frequent. You can use it, but sometimes you can use it. And what we use it for, we only use it for sequestered disc. So when you only want to take out the disc prolapse, and then you don't want to evacuate the disc space because you have no ability to really angulate your instruments. Okay, one example here behind L3. You see the approach, then you need X-ray guidance, that you have an ideal approach. You have to have the tip of the tube right at the lamina and the direction of the tube right to the migrated disc. And this is the intraoperative view. So this is this time obviously it's a 3 millimeter burr, a smaller burr. And then you open this up. This is a 3 millimeter punch. The section is about 2 millimeters, so it's a very focused opening. So here at the end, the opening might be 4 by 2 millimeters or 5 by 3 millimeters. And then you take out the disc space, the sequencer. Another case, there we have a video. It's 4-5 caudally migrated left side. Orientation, this is medial, lateral, caudal, cranial. We can move a little bit further. You see now that there's a very small opening of the spinal canal. So you really have to know where you are, because otherwise it's so easy to have a dural tear. So opening of the spinal canal is much more difficult in this case than in a standard case, because you come at the area of maximum compression. So you have to do it step by step. Again, for the diameter, so let me stop here. This from here to here, the diameter of the tube is 13 millimeters. So this is 2 millimeters, just to get the idea what the magnification is. Okay, so this is about 2.2 millimeter diameter. This is the suction device. You can orient what the size is. So exposure is maximum of a 4-5 millimeters of the lateral recess. And there you see now, oh, sorry. At the end, you saw nicely now you see the root coming here, decompressed, right? So we evaluated our cases. We do not plan this specifically, to be honest. So we just went through our cases, and one in which situation we did a shear translaminar approach. And this is about 10% of the cases, so not that many. And then we just did the standard follow-up of the patients. So it's 31 patients, mainly a 4, 5, and a 5S1. So a 4 lamina and 14, a 5 lamina and 11. The migration of the disc was more caudally in 26, a little bit cranial in 5. Mean follow-up is 3 years. Mean overall operative time of 54 minutes and 10 procedures. We were not sure intraoperatively whether we really had an intact lower and upper border. So we called this enlargement, although it was not obvious that we detached anything. We did not reach the ligament, but we called this enlargement. And then in 18 cases, there was an additional discectomy for just the bulging part. And the mean diameter of the drilling was 7 millimeters, so it's quite small. And there was no emergency stopping, no nerve root injury, 2 CSF leaks, which were closed endoscopically. And these are the clinical findings. Postoperative improvement of radicular pain was in 96%, paresis in 86%, and sensory deficit for some reason, which I think is less likely to benefit 100% in this group. Mean pain intensity at the final follow-up was 1 in mean, but there of course were some with had up to 7. And the follow-up of with 3 symptoms was in 88% after 3 years. And the mean pain intensity remained better. So you had to reduce this 7 to 3. Paresis was good in 96%, and sensory deficit good in 89%. We had some complications. There were 2 recurrences in the follow-up in the 3 years. So this is one early recurrence. Where is that? Here. This is the one within the first week. And this patient, we did then microsurgically, not for any reason, but there was just nobody available for endoscopic approach. I was abroad. And the same patient had another recurrent disc at this adjacent level. So patient of this patient totally had 3 spinal surgeries. after the initial surgery in 1.5 years. And then there was another case with a recurrent disc after 2 years, this one here. Yeah, there was another repeat surgery for lateral recess stenosis in an adjacent segment. So overall, 4 patients had another lumbar surgery. So to conclude, the endoscopic technique is a safe and effective technique for resection of caudally and cranially migrated lumbar disc herniation. In selected cases, the bony border of the lamina and the ligament attachment can be preserved. Immediate postoperative pain relief was achieved in 98% and clinical success in 89.7% of cases in the long term. And the rate of recurrence disc herniation was 4.8% with a mean follow-up of 37 months. And you can look this up. All these are in the PubMed. And also on the translamina, we have made a paper. And this is our department, old picture. And this is the Saarschleife where I tried to kill someone, but he survived. Yeah. We're not experienced with that. And if you have any interest, you're happy to come. We're happy to welcome you in Hamburg for our endoscopy week. It's 11th week this year. It's in the September 11 to 17. It covers skull base, cranial, and spine. Thank you for listening. We have to discuss now because then I have to go to the OR. Is that right? Or who is next speaker? No speaker? You're next speaker. Shall we do now or shall we discuss? Let's discuss, huh? Any questions? Come, not sleeping. Hello. You have to, but this is really, you have to get this like an opportunity. Just, be angry with us, fight with us. I will not remember.
Yeah.
Put the microscope in somebody's face. That's a nice description. I like that.
Sorry.
A microphone, yeah, sorry.
Sorry, Nikolai will have a call.
No, I have to go for the OR. This is why we have to discuss now.
Okay, good. Who are questioning what?
Yes, I want to ask about how many cases do you operate with single biopsy forceps? Isn't it too costly?
What with
pituitary rongeur you remove with that you are removing disc? How many cases do you perform with one biopsy? One biopsy forceps.
To replace your pituitary.
After how many cases do you
replace your pituitary or does it work forever?
He's not concerned.
To be honest, I have no idea. Well, I can tell you. Well, usually I have no idea about the replacement. The only thing I can tell you is that since February 2020, we don't get new instruments for the EasyGo. Because since then, it's not manufactured anymore for the European market because it's not permitted. We can use the old systems, cannot use the new one. I can tell you that we do about 60 to 70 cases per year with one set, and it has not replaced for the last 2 years. So it's 120 cases, but I don't know how often I use the pituitary.
I want to ask about how much medial facet has to be drilled and how much is safer for endoscopic resection for reaching to the lateral recess in the disc surgery.
Well, for the drilling, you need a diamond burr. So the diamond burr has the disadvantage that it's very hot, so you need irrigation. The big advantage is that it vaporizes the bone. So you don't have to, you just suck it away. It's a little dust. Most of it is vaporized. So it's just gone. So then it's easy. If without the diamond burr, these procedures cannot be done. You can drill, of course, with the regular burr, but then to be safe, you have to drill at the attachment of the ligament, that the ligament covers the dura. And then you have to continue with the caries and punch.
No, my question is about the percentage of how many millimeters you have to drill this one. Because in open discectomy.
Do you mean how
if-
deep the drilling or what?
lateral one, medial facet, how much medial facet
do you take when you're?
take for reaching to? the
Well, it
lateral
depends on the case. In the young case, you don't take any facet. In the old case, where you have facet hypertrophy, it's very big, then you have to drill a little bit of the facet. There's no other way.
If there is facet violation for unilateral, so does we need to do something fixation at the same time as we think when like? in
Oh, no,
open surgery?
we really had not a single case was unstable in this because, well, you don't have to take the facet.
Okay.
This is a big advantage here. It's really shear in the lamina. You don't see the ligament. This is also dangerous because you go down and at the end of the drilling is the dura. So you really have to know what you're doing. It's not that easy. So I'm surprised that it went that well. So we only had 2 dural tears. But then at the end you have a thin, so it's like when the ENT do the transpetrosal approach for the facial nerve, at the end you see a thin bony layer and then you just open this up and then the dura is there. Yeah. Well, you can only put it on the dura when you have. The problem here is you have to drill a hole in the lamina. You're not starting at one side.
So it's interlaminar, that's why you don't excite. In fact, you need the diamond.
Yeah, you need the diamond. Actually, if you have the diamond burrs are a little bit different. They usually don't like if you put pressure on the tip, So some give you some engines, they give you a hard time. In some, I think we have Escalab and Medtronic is fine, but some others don't like this, some other brands. But you need to drill a hole because there's nothing. This is not, you cannot use a side cutter. You need to drill the hole first and then you can enlarge with a side cutter, but without the hole, you cannot use it.
No, what he says is, I use the same thing. I use stick. Many times I tried, after I see you and after you start talking like that, I go and try diamond. And then I do a couple of cases with diamond and it's heating and it's too slow. And I go
it's very fast.
And I go, well, not for me. And I go back to my,
why?
I don't know, maybe I don't know how to use it. So
The drilling time here in such a case is maybe 2 minutes.
Yeah. So I
seriously,
I
it's
feel
not
more comfortable to use the matchstick because the matchstick has the tip that works like a diamond and it has side that works a bit more aggressive. So I can, with time, I'm very confident to drill anywhere with that. And
you can try, but in these, I mean, in the larger the approach is, the easier it is. Here, to be honest, you touch every time with the drill, the drawer, every time. So you need 100% security. Don't do this with its minimal, this is really small approaches. Don't do this.
Yeah. Okay, your question?
So I have got easy go one, but I find it very difficult to go to the lateral cells. Any tips where to point the scope or?
I don't know what we're gonna have in the workshop. Well, easy go one, well, the 2 is much better. There's some advantages of 1 and 2, there's some differences, but overall the big advantage, the big change from 1 to 2, I did not point this out. The big difference is that you have much more space to maneuver your instruments. So the connection between the tube and the endoscope is much better. So then you have more space, you can manipulate better.
And is there any difference in the angulation of the scope? I mean, if I put the camera on the side of the surgery, I see only medially, and the lateral recess is totally, I can't see.
Well, then actually your skin incision is too far lateral. If you have this problem, then you're too far lateral. Yeah, because then you have, with a straight approach, you have the facet in your way to access the lateral recess. Then you have to be closer to the spinous process. Go as close as possible.
Okay.
Maybe Artem, you can also comment. Artem has a very, very large experience on EasyGo. He was one of the first centers. We did I think in I don't know, the WFNS meeting in Boston, I think we did a symposium. So Artem has what's your comment about the lateral recess?
Yeah, it's the main advantages of the EasyGo system that you can rotate in endoscope around the port. You can see all the hitting the place, and I just rotate endoscope immediately and to reposition a little bit the port, and you can see lateral recess if you just change the view angle. Two. Yeah.
Yeah, but originally you had one.
Yeah, but now
originally you started 2009. He had one.
Yeah,
your first 100 cases were minimum.
I didn't see any differences, but now we're using two.
With the very small approaches, it's much easier with the two.
Okay. Any questions to Joachim or to my talk from here? Yeah. Sorry. No. These are silent persons. They must ask. Questions.
Why can't we make any consensus about the equipment, minimum number of instruments we can safely use for the surgeries, endoscopy?
So when are you taking what? Well, of course, well, the main problem is that it depends a lot on your personal experience. And then if you are to tell you, if you need to expose everything to find your anatomy, these techniques are nothing for you. Don't do this, because then you will lose orientation. You will have disastrous results. So, and then you blame the system or the idea. The problem is you. And so we had a lot of discussions on different techniques. So it's like when you use the translaminar technique, some have excellent results. Some have 60% so-called recurrences, which is because they never reached the disc prolapse. And here we had a big discussion with South Africa. And I think I don't know what they do, but I told them to come because they had a complication rate of more than 50%. You know who I'm talking about. Horrible. I don't know. There must be a systematic error. And this is published, these results are published, and I really have no idea what they do.
Complication? You mean dura laceration, root?
Everything. Dura, root injuries, everything. Horrible.
I'm impressed with the honesty.
Okay. Yes.
So, just out of curiosity, why is the EasyGo no longer being sold in the European Union?
Well, right now we have no endoscope sold in the European Union. No endoscope for neuro. Not a single one. Not intraventricular. No, it's not true. I will point this out. Intraventricular, we have Escalop, because they took the chance of extending their permission to sell it, the only company, but this will end in 2 years. All the other companies missed this chance, and there's a new EU regulation. And with this regulation, we have no endoscope. No, not only storage, no endoscope, no Medtronic, no Revo spine, no endoscope right now for lumbar. And we have no endoscope for cranial.
This is because of bureaucracy of European Union.
The problem is that they made a new law, and this law no longer permits to transfer results from one study with, let's say an endoscope with the same material to a new endoscope with the same material. This was allowed before. So they did one study, let's say for EasyGo, and then the biological behavior and everything of the endoscope of the EasyGo was accepted to permit the use of a spine tip endoscope. And now they want a study for each individual instrument and telescope. And this is by far too expensive because there are some telescopes, they only sell less than 100 per year. And it's a big problem because these studies are very expensive and they take a long time. But it's not only EU, it's also the company's fault. Because the companies, this regulation started in 2000, 20 years ago. It was extended and delayed and delayed. And now for the last 2 years, it's active. And since then, nothing is available. So we hope that actually, my last information was that in May, EasyGo is going to be back. And at the end of the year, Lotta is going to be back. They will no longer sell GARP endoscope, which I think is a pity because I still use it a lot. Good that Henry is not here, but because I think it's the best endoscope available. They will no longer use OI, so we also have to throw away OI. We have OI, which I think is perfect for pediatric. Medtronic will not try to get into the market. RevoSpine will be back. And Joymax, I actually don't know. I have no contact. I did not talk to them.
Yeah, it's unfortunate that these guys were given a chance to comply and do these, and they did not work on it, thinking that they'll get extension again and again and again.
The problem is they didn't do anything, and now the permitting authorities have like a huge pile up of reports and applications from the various companies, and it just takes years to get one system permitted for surgical use now.
So there are.
So this is not a unique EasyGo or Storz thing. It's
So
all of them.
We can buy here. So I know the people who have bought. I've bought for somebody and then shipped it for them. So you guys don't apply.
Okay.
Well, I think in Britain, in Great Britain, you can buy it. Why not? This is it's possible.
Okay.
Don't push me.
Thank you.
We will be fast.
Thank you, Joachim. Yeah, very nice discussion. And I invite Nikolai to give a talk on transforaminal endoscopy.
So I have tried at the time when I was deciding which endoscopic system to develop, I've tried EasyGo. I've done a few cases with EasyGo, and at least for the interlaminar work, it was not big enough step for me. So I decided to develop full endoscopy service. I started myself first with the transforaminal endoscopy, and I hear opinions that this is intuitively you may start with interlaminar endoscopy because you will be more familiar with the views, you will be more familiar with the anatomy. However, it appears that it is the right thing to do is to start first with the transforaminal because you get more familiar with the instruments, and it's a better way to start. So I was hoping that I will do a case today, but unfortunately we don't have a case. So we will do some cadaveric work later. I'm going to demonstrate to you the approach, which is the transforaminal approach. I'm going to give you now a few tips of how to start if you are planning to start that. So of course, the best way to start is if you go and have a fellowship somewhere and have a proper training. But unfortunately, many of us are busy in life and busy in work, and you don't have time to dedicate for a year to go somewhere and have a proper fellowship. So the alternative to that will be Cadaver courses, online resources. There is plenty of them now. You can go for short-term observerships. You can go for, and then these companies which you decide to work with, they will support you with approved faculty that will come and do cases with you. So that's an alternative way to start. It's going to be longer and a bit more difficult way, but it's not impossible. That's how I did it. So if you are trained to do only microscopy, and if you want to start with the endoscopy feels like it's a pretty tough problem, pretty tough walnut to crack. But if you crack the problem to smaller problems, it's not that difficult. So if you want to crack the problem to a smaller problems, is you have to learn about the surgical anatomy. You have to learn the X-rays and how to get proper X-rays and proper orientation. And this is not by chance in red. I put it in red because I believe that this is the most important. Injections, I put here injections because the first step of the interlaminar approach is basically transforaminal injection. So how I started doing this initially is I started using the same approach for the transforaminal injections. I was using long needle, and when I was doing, I do a lot of injections, and when I was doing injections, I was using the same trajectory. And like that, I got good experience of the trajectory and of the X-ray anatomy. So this helped me a lot. Previous experience is also good. If you already do minimal invasive surgery, if you already do cranial endoscopy or any other type of endoscopy, you will not be completely new in endoscopy, and it will be possible to have some understanding of how the endoscopy works and how to orient the endoscope, etc. The rest is team selection, very important. Your radiographer has to be somebody that understands how to give you good pictures, for example. Your scrub nurse has to be experienced or has to know what to do. So the team is very important, especially when you're starting something new, something that you're not very familiar with and very, very confident with. I mentioned to you about the support faculty surgeons. And then finally, when you align all the ducts, you go and do it. So this is the anatomy that we normally are familiar with and that we are trained to use. So this is this is in yellow here is the area that normally you approach when you do your decompressions, when you do your discectomies. You have this area that you normally expose. You will do the cutting of the bone in case you would like to address disc herniations, for example. Most common area of disc herniations on that side of the picture. However, when you would like to do full endoscopic interlaminar approach, you have completely new perspective. You can see here that instead of going medial, you have to go now lateral to the facets, and you come and you approach the foramen in an oblique and the disc in an oblique way. So that changes the perspective quite significantly for you. And when you start using the endoscope, and when you have this limited access and limited view, that's very confusing in the beginning. So you have to have a good knowledge about the anatomy. And that's why previous experience in that anatomy is very important. If you do minimal invasive TLIFs, for example, that will be something that will help you because you've been many times on that side and you know that perspective. This is the working channel that you will have, and the working field. That's where you normally work when you would like to do endoscopic transforaminal discectomies. So famous the Cambin's triangle. But with the transforaminal endoscopy, you don't even use the whole Cambin's triangle, but you use only a small part of it. The part that is overlapping the disc, and this is where you are focused, and this is where you you do your approach to be centered to. So the end plate will be the lower end plate is your best friend. So when you are working your approach, you have to make sure that all of your instruments are very close and aligned to the lower end plate, where is the safest zone to enter the foramen because of this specific anatomy of the nerve. You can see it here. The nerve is coming obliquely, and if you come close to the lower end plate, that is where you enter, and this is how you don't injure the nerve root. So this is the importance of that diagram. If you go closer to the lower end plates, this is the trajectory of your instrument, and your nerve root is left laterally to your instrument, and it's not going to be injured. If you go closer to the upper end plate, for example, it goes straight over the nerve, and then it will injure your nerve, and that's going to be a serious complication for you. And if that happens in the beginning of your attempts to start endoscopic surgery, that will put you off most likely. X-ray anatomy is extremely important. You have to have good understanding for the X-ray anatomy, and you have to make sure that you can match all these known objects like pedicles and facets and the TP and spinous process. You have to be very confident that you can nicely discriminate everything on the X-ray, because unlike the open surgery where you open widely and you have your landmarks with the minimal invasive and endoscopic surgeries, your eyes will be the X-ray. So you rely 100% on your X-rays, and so you have to have good X-ray acquisition, and you have to have good X-ray understanding. And this will be the following couple of slides. I was said that even if we discuss and demonstrate some cases in Cadaver lab lately, we will not have the X-rays. So the X-rays will be very important. So I will focus some of this to X-ray understanding. So image acquisition technique is extremely important, and you have to relay on that to a good X-ray technician that will give you good X-ray pictures, true AP and true lateral. That's very important. If you don't get that, that will mislead you badly, and then you will have serious complications. So make sure that before you start, you get a true AP picture. What is true AP picture? The end plate of interest has to be seen as a line. As you can see here, straight line here, but not like elliptical. So this is not a good true AP for that end plate. This is AP for that end plate. This is AP for that end plate. The other thing that you have to make sure is that your spinous process is right in the center, because this also can give you the so-called parallax, and that can mislead you, and you will believe that your instrument is somewhere, but actually it may be completely on a completely different place. And with that surgery, millimeters matter. So be sure that you get good X-ray, true AP, true lateral. Make sure that you talk to your radiographer in the beginning what exactly you want and what exactly how you want them to behave and to give you what images. Same thing applies for the lateral. You need true lateral image. This is good true lateral for that end plate. This obviously is something that you should not be happy. And if you would like to work in that foramen, you have to make sure that the radiographer is changing the trajectory of the beam of your X-ray, so you get true lateral picture. Access point is very important, and because you don't have completely widely opened space, you are relying quite significantly on very precise starting point, very precise access point. So you cut only about 5, 6, 7 millimeters of the skin, and you don't have much room for manipulating of your instrument and angulating your instrument. So you have to be very precise when you put your skin cuts. Obviously, level-wise on the lateral, you can easily position your cuts, but when it comes to how lateral you have to go with your starting point, then this is a bit more complicated. So I try to give you a diagram to roughly guide you, and that will give you a rough guidance of how you will not end up in a completely wrong position and how you will not have a major complication if you start. So most of the companies that will give you guidance how to manipulate and how to access with their instruments will give you these numbers. These numbers are just rough orientation. They cannot be true and they cannot be equal for every patient. This cannot be true for somebody who is 70 kilos and for somebody who is 140 kilos. And you will have these variations in your practice. So these numbers are orientation. You can use them when you're starting as a rough guidance, but they are not 100%. So I hate to remember numbers and then they are not reliable. So that's why I like to use this diagram with the colors. So roughly your entry point has to be in the green zone on the lateral X-ray. So if you put your instrument on a lateral X-ray, that has to be in that green zone, and the green zone is the area that will take you in the foramen safely. If you go in the blue zone, you will go too much lateral, your trajectory will be too much lateral, so you will not be possible to enter the foramen. If you go in the red zone, it will be too much, you will be below the foramen and you can injure abdominal organ. If you are in the high levels, you can injure kidney, retroperitoneal organs, so be careful with that. So basically your entry, this one. So this is the midline here. This is the midline. This is, I'm going lateral. This is top, this is bottom. So your entry point should be somewhere in that green line, green area, depending on how lateral or how medial is your disc. If your disc is paramedian location, for example, you have to go more lateral in order to get inside the foramen and to achieve good penetration. If your disc is lateral or even far lateral, you can go as close as 10 centimeters to the midline, and like that you will have the proper trajectory. If you go too much medial, then you will be entering the lateral triangle here, and you're gonna be sliding, going down towards the retroperitoneal space. If you go too much in that red area, lateral, you will you risk your trajectory going through the retroperitoneal space, for example, and you can go through a kidney, and you can have a kidney injury. So you don't want that. Right, so B-planar awareness is very important. You always have to check your instrument on 2 dimensions at least, AP, true AP. I cannot stop repeating and emphasize that true AP, always true AP and true lateral. Be very demanding for your radiographer, true AP and true lateral. And you follow the first step of this procedure is, you will see it's a long spinal needle that you have to dock on the, usually the superior articulating process, or you go with some systems, you go straight in the foramen. So you have to be possible to put the top of your needle in a specific location, and then I'll demonstrate exactly how. So always follow the needle in 3 directions, true AP and true lateral. And this is the end point. This is the 3 bars that you want to get. So on AP, true AP, the tip of your instrument has to be no further than this line, and this line is the line that is drawn just medially to the pedicles. So this is the medial pedicular line. So the tip of your instrument has to be no medially located than this medial pedicular line on true AP image. And in that case, it is very important to make sure that the spinous process is right in the center. If your spinous process is eccentric, you may think that you are on that medial pedicular line, but if you see that spinous process, for example, going contralaterally, you actually will be further inward. So you might be inside the dura if you don't make sure that your spinous process is right in the middle. So that's where very important for you to make sure that your instruments are tracked on a true AP and true lateral. Same thing applies on the lateral. So on a true lateral X-ray, you have to make sure that your instrument is no further than this posterior body line. That is the line that connects the two vertebral bodies, the posterior walls of the two vertebral bodies on a lateral X-ray. And this is the starting point of your needle. That's where the needle has to be docked when you're starting the interlaminar approach. And this is a good picture that demonstrates this again. On that drawing, you can see that if your tip on the lateral on AP is as demonstrated above, then you are right next to the dura. So this is the position that you would like to have in order to start your surgery. This is your starting point. A few positions which will not be correct. I have already commented that if you see your tip of your instrument past that line, that is not great. If you see that instrument past that line, that's also not great. So you're here well deeply in the disc, so that's not a good docking. So you will not get a good surgery with that. If you have this situation, that's even more dangerous. So if you see on lateral that you are on the posterior body line, but on AP, you're past that medial pedicular line, then you're intradural. This is a picture that is demonstrating that your instrument is intradurally. So you don't want to be intradural. You don't want to stick more. So make sure that, and remember that over that needle, you will stick a dilator. Over dilator, you put a cannula. Over cannula, you put the endoscope. So until you see what's happening there with the endoscope, you already put a lot of instrument. And if you're intradurally, you already had a big devastation and your patient has serious complications. So this is why the X-ray anatomy and the X-ray, the initial docking is very important. So when you're starting your surgeries, you have to make sure that your initial docking is very precise, and then the surgery will go. If that's not what you've done, then probably you will have big problem. This could be another problem. If you see that on the medial pedicular line, you're okay, but this is too deep. So you are here in the posterior, the retroperitoneal space. So that's another problem that you can have. So I mentioned to you that the first step is the needle, but the second step is you're putting the key wire. You can see here after you achieve the tip on a specific position, then the second step of the surgery will be you're putting the key wire inside, and then you remove the needle, and then you slide instruments over the key wire. This is what is happening here. And after the key wire, the second step will be a dilator. You put the dilator, and you follow the same rules on AP and lateral. You have to be on no medial than the medial pedicular line with the dilator. And then the last step before you put your endoscope there is you put your working cannula. Very important tip for the working cannula when you're developing your approach is that because the cannula is beveled, you have to make sure that when you're inserting your cannula over the dilator, the bevel has to be with medial orientation. So usually with all the working instruments, all the cannulas, the outflow of the cannula will demonstrate where is the opening of the bevel. So here you have the opening, which is located laterally. And this is the right position for you to start, because otherwise the bevel, if you are not started laterally like that, the bevel will be located towards the nerve, so you can have a damage of the nerve when you're drawing your cannula in. So the right thing to do is you put your cannula inside the foramen with the bevel, with the opening of the bevel laterally, and then once in the foramen, you rotate medially. So like that, you can have the access towards the disc, which is here. So this is very important tip for you to know and to remember. And again, on the X-ray, that is demonstrating that you are rotating your cannula, your working cannula, only when you are inside the foramen, but not before that. Otherwise, you can have serious damage of your exiting nerve root. No, that's it. Yeah, that's it. The last step is putting your endoscope when you're starting with the surgery. I mentioned to you about this. The last slide, choose your first cases. The first case, you should be somebody who is slim, fit, ideally L4, L5 disc herniation, paramedian location, recessional disc ideally, without any migration, no degeneration. So you don't have this situation, but you have this situation with nice, large and wide open foramen. And so make sure that you are aware of the anatomical variations. So make sure that your iliac crest is not on your way. So this is my points for you when you decide to start. Thank you. The rest, hopefully, I'll be possible to show you in the in Cath lab.
Hello. Yeah. So actually, they are ready. What we will do is once we show this, then we can have a discussion, and then we have more discussion.
Yeah, that was the idea.
With our itself.
Yeah.
You guys, if you have questions, just hold on to them. Can we connect? Okay. Yeah, you have to take us through what that is. Okay.
Good.
Okay. Yeah. Okay. Boss,
Okay. Are they with us?
yeah. Joachim.
Okay. Can you hear us, someone?
Yeah, Joachim, it's me, Christoph. I will guide a little bit.
Yeah. This is the comedian. I cannot see you.
Okay. Yeah, we hear you very well. Excellent. We hear you excellently.
Is this okay for you?
Very well.
No, I don't hear you.
Okay, we hear you very well.
Oh, very nice. Now it's better.
Okay, Joachim, do you hear us?
Yeah, I hear you better, but better than nothing.
Okay, yeah, we hear you excellently.
Okay, so we did already one lateral X-ray. Oh, where is that? Can you open up? Yeah? So we did a lateral excitation position. It's here to see. You see it's a prone position, decompression of the abdomen, rather small, lady, not obese. And we did the lateral X-ray with the needle to mark the level 4-5. This marking is here. You see the midline and exactly where we put in the needle. Okay? And these are the MRI.
Joachim, is there a chance that you can please show us the MRI scans prior to the surgery so that we...
I'm just showing you the MRI.
Excellent.
Just let me do it and then you can discuss. So here you see the MRI. You see a disc prolapse 4-5 and the axial, so this one.
Can the camera please go nearer to the images?
Yeah, show this one. Oh, show this one. Can you show it?
We do not really see it good. Yeah, now it's get better. Maybe even bigger. Make it even bigger. Very close up.
You see it?
No, it's too far away. It's not really good to be seen. The camera has to zoom in. The camera has to zoom in more. Closer, closer, closer. More, 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 more. More closer, closer, closer. Maybe that's the maximum of the camera.
Here's the best to see the products 4-5 right bilateral.
Yeah, it's roughly a little bit to see.
Still it's here. This one. Patient has a right radicular pain with a small paresis of the toe extension, so L5 extension. Look at this. Okay, come back here, show him. Now we do the washing. Now the audio is much better.
Okay.
The problem is I don't see what you see, so I don't know.
We see currently your surgical field currently washed. We see the markings you did on the skin, and
much better. Okay, okay. Now I know what you see. Very good. Thank you so much. Very good. Okay, we have 2 more minutes to go. This will be very challenging. It's only one procedure, and usually something is always missing. We try to set up everything, but we will see. We have to wait a little bit.
So yeah, I mean, you marked the height 4-5 on the skin. Is that correct?
I explained it already, that we marked the midline and the puncture point of 4-5. You did not listen. Okay. We need 2 more minutes. Use the dot. So in this procedure, the goal will be to decompress the L5 root. Actually, it's L5 radicular center. Right side. To the right is the head, to the left is the foot. On the, yeah, on the other screen. No, it's not there anymore. We just have to have the endoscope holder, don't forget it. No, here, this side. This side. What is the next after live surgery? We have lunch, or what is the next thing?
Lunch. Okay.
Okay, then we have no time for 5 minutes break. Okay, you have to watch us draping the patient.
Okay, can you please show us the field again?
What?
we do not see the field, if the cameraman can please show up field again.
Yeah, and can you show me the screen again? Now I see the auditorium, which is of no interest to me. I've seen you for the whole week. Just show me what you see. It's easier for me. Yeah, thank you, thank you. Because this way I know what you see. It's easier to explain anything.
So Joachim, do you see now what you want to see? Do you see?
Yeah, yeah,
now
it's
or do you-
perfect, perfect. So
Very
to
well.
the right side is cranial.
Yeah, now we see only you
To-
again, Joachim. I do not.
Yeah.
कैमरामैन यार आप ऑपरेशन थी दिखाओ कैमरे वाला
The right side of the
Ah,
screen.
this
Yeah,
is right.
like this. Just leave it like this. It's too close. You're too far away. Go closer. A little bit closer, otherwise it's too bright. No, no, stay with this. Stay with this. Do this one. Don't change it. Just stay with it. It's fine. Okay, so this one. If until I tell you to do other. This one. This one. It's not seen. Yeah, now like this. Okay. Stay with it. It's fine. It's okay. Don't go too close. Perfect. Okay. So we just do the draping now. As soon as we do anything of interest, I will get to the other camera. Yeah, good, good. So now you see. Let's go. So this is the midline, and this is L4-5. This here's the puncture level. We did puncture on the left side. Okay. Now this camera, make this active. Change it. Yeah, perfect. This camera, and now we just do the setup. We'll take another 5 minutes. Sorry for about this. Okay. Okay, I don't care. It's fine like this. Don't do that. We need the holder. So there are many different opinions about holder. I like the mechanical one. It's cheap and completely fine. You don't need the other one. The other one is up to 50,000 euros and it's pneumatic. And then always you cannot do a little adjustment without much force. This is now here. Where is it? Yeah, please. Good. Yeah. Fix it.
So Joachim, please can you tell us why you put the holder where you put it exactly? And what's important for the assistant if he places the holder?
Well, the thing is for the holder. Oh, this is a very wow. You need some oil, Salman. Wow. Ay, ay, ay. Okay. There's shortage of oil in Pakistan. Oof. It's very firm. No, it's fine. It's fine. It's no problem. I just need my force. Usually we always do it like so. The thing is, this is easy go 1. So we have to adjust a little bit different from 2 because the connection from the tube to the endoscope is different. I will show you in a second how to put the connection. Okay. So I have not checked that the set is complete. We will see what we can do. We have a drill.
Joachim, you should maybe mention that it's important for the system who's doing the holder that it should be in a place where it does not really disturb the surgeon. So
Wait. I will show you with big one, big diamond, only diamond, big diamond. Okay, very small, but okay. This is 4, no. Really? Okay, section, we have diamond, wonderful. So let's see what we have. You have the tube with the various dilators. Where are the tubes? No, the trocar, the tube at the end, the operating sheet. All right, give it to me. You have only that one? Okay, only this one, the green medium. Is that the one you have? Okay. So we have the green medium lengths. There are 3 different lengths available. A short one, which it's much easier to use, and the long one for US. And we have usually a yellow, a orange, green, and black. Black you can put cages in. Green is for stenosis, and then the orange one's for this. Here we have the green one, which makes it much easier for me. But it's 18 millimeters diameter skin incision. Okay, good. I will explain the holder to you in a second. So it's important with the holder. I like to have it on my side because when I have it on my side, it's easier to have a straight down approach and to have it not on your way. The holder always gives it a little bit, the weight, a little bit that the tip of the tube points to the midline. Okay, so can we start? We have to do safe surgery. We did this. Same, right patient. What is the operating time? 45 minutes. Blood loss? 0. Are you okay with that? Okay. You have no problem. You haven't had any problems? Good. She's not going to stand up when I cut her now? Okay. So now go to this camera. Perfect. Okay. So this is caudal, cranial. This is our 4-5 marking. This is midline. So we want to pass the spinous process. So we will cut here, right here. So if you have the problem that all the time you do these cases, you have to resect the facet to do the lateral recess decompression. Sometimes it might be like in a standard case, but usually you're too far lateral. So just stay here. So we do the skin incision. Should be large enough. We have a Bowie knife. I usually don't use it, but we have it, so I will use it. The good thing with the Bowie knife is that it avoids hematoma of the subcutaneous tissue. And now we dissect the fascia. Dissect the fascia. Okay. First dilator. So for this lumbar approach, it's fine, the smallest one. We don't use the wire because with the wire, sometimes you can enter the disc, the interlaminar window. So here I use, you don't need to be, don't need to. I use the smallest dilator and I'm right on the bone here. I'm right on the bone, so I know I'm right. I feel the lamina L5, L4. Very easy. So this bony contact is important. And also you feel the disc and the facet. The facet is lateral, okay? So this will be a perfect approach. Then we need the next dilator. Oh, you need oil here. Ay, ay, ay. Good. You have to feel the bone with all the different dilators. Now we have the green one. So green marking here. You see that? Green marking. Yeah, no, it's fine. Just stay with this. It's too difficult to switch all the time. Just stay with it. And then we also see the depth is 4 centimeters here. So would be ideal for a short tube. We don't have it. So we have to use the long one. Now I have to have the bony contact with the tube. I feel it. Very good. So now you see that the tube is by far too long for this case. Very thin lady. Anyway, cannot do anything, right? So we connected now to the scope, to the holder. Ay, ay, ay. I think it's not open. No. Oh. No, we need the right projection. So, good. Okay. So now we connected with the connector and the tube. Let's do the tube. Where's the, yeah. Okay, here's the scope. Okay, white balance you have done.
Joachim, there's a question from our auditorium. If you could please show us the X-ray again, the needle X-ray, the last one.
Okay, go to this camera and now the X-ray, this one. Can you open this up? Yeah, there you see the X-ray.
We currently do only see the slides.
So the X-ray, do you see it?
No, at the moment not. Now it's getting better.
Okay. 4, 5, iliac crest, this perfect approach.
Okay, Joachim, the auditorium is asking if there is a chance you can do an X-ray when your tube is in, so that we can see the approach.
Well, this will take 10 minutes. Okay, we can do that. Let's do an
Yeah,
X-ray.
well, if it's too long, then no problem. Then maybe you
Well, it will be. I would not do it because
Okay.
I'm sure with the marking that I'm at the right level.
Okay.
Let's rather proceed. If we have a problem, we can still do it at the end. So now we have put this in, and then can we reduce the height of the table? Table down, right? Table down, 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 down. It's full down. Oh yeah, yeah. Okay, so where's the bipolar? And this is the drill. Good. Okay, now switch to the scope.
We already see the scope.
Okay, but the bipolar. It will take a short while to get you a clear view. 40 is fine, no problem. I feel already the bone. You need irrigation. I will focus in a second. Okay, now some grasping forceps. Pituitary forceps, the big one. No, pituitary. Okay, good. You think it's a lot of tissue, but it's just a maybe 4 or 5 millimeters remnant connective tissue because I'm constantly here, feel the bone. You see that? There's the bone. Okay, we will focus in a second. I used to drill the bipolar to shrink the tissue that I can get a better view. You don't need irrigation now. It's fine. Okay. So this very firm thing, I have to move a little bit to the middle line. Okay, like this. Good. Okay, so now we focus and now we need the drill. You can record. Okay, but the drill. Orientation is the right side is the same, is cranial. Left side is caudal. This is midline, this is lateral. Okay.
Joachim, can you please explain us the orientation again? Where is your?
I just did.
Yeah, first, what?
This is cranial, this is caudal, this is midline, this is lateral. Okay. So now we drill. Works very well. A little bit more saline, yeah. You have to clean the lens. This is the issue. More irrigation, it's very hot. Good. So we have exposed the ligament now. Let's see if I can focus a little bit better. I think it's focused. Cannot improve this. Bipolar. I use the bipolar to shrink the tissue again. Okay. Okay, now we need the small hook. Let's see what we have. These instruments are too rough. No. Small instrument. There's a small hook with it. Very small one. It looks, no, it's a straight one. Straight one, smaller than this. Three different ones. So we wait for the hooks. Yeah, but this is a dissector. You have a hook? Hook, okay, this is very good. So we have no hook yet, but we will try with the dissector. So we are here now. We detach the ligament now from medial to lateral. Why from medial to lateral? Because I don't want to be too far lateral at the end to have the injury at the nerve. Right? So I need what kind of Kerrison punch you have? Give me the 3 mm. 3 mm backhand.
Yeah, now.
Sorry, I did not hear you.
Now everything is fine.
You see the size? This is a 3 mm Kerrison punch. Now we don't see anything for some reason. No, maybe clean it. Just clean it. Right. Yeah. Okay, I can do that. The dissector would be very good, particularly to check for the nerve root decompression at the end. No dissector yet? No, no hook yet? Simon, you cannot do any cases tomorrow because I open up all your sets. So I usually use a hook to perforate now the ligament, and we wait a little bit for the hook. So give me the dissector, this new one, the newest one. Okay. Ah, hook. Perfect. Yes, thank you. You have a smaller one? This is, look at this. The hook is as big as the opening of the spinal canal. So I open the ligament like this. Okay, now we're inside the spinal canal, and now we open from medial to lateral to preserve our structures. It's good. 3 mm carries on punch. It runs very smoothly. Thank you, everybody. You're very good. This is absolutely outstanding for the first procedure. Really, very absolutely outstanding. So we see the dura now. Okay, give me the hook. Any the smallest one you have? Yeah, wonderful. So we try to pass now the thecal sac, and I feel the disc roll up. I feel, you see here the root coming off, getting off. I'm right at the shoulder of the root. This is L5 root, right under my section. And I feel here the roll ups. So perfect case so far. But to decompress the root, I think we have to drill a little bit more caudal. Right now, it's strictly in translamina. We will see if we can stay like this. Drilling. Mm. Okay. Let me see that we have a clear picture. Yeah, good. Okay. It's a little bit out of focus, right? I think it's dirty. It's dirty. Yeah, but somehow it's not. You see, it's there. Okay. Better in the. Yeah, now it's better. Okay. Bony border is still okay, so it's still pure translamina. One particular thing in these cases is that we try to manipulate at the root as minimum as possible, because if she has post-op root swelling, the opening is much smaller, so she will have sciatica. So try to limit the manipulation of the root. Can you close my nose? I spoke too much. Yeah. Thank you. It's more. Yeah. What? So you see the root here? Easy to see. Here's the axilla. There's the shoulder. We go through the shoulder. Try to retract the root. Give me the retractor. It's fine, it's fine. No, give me the smaller one. Press the hook. I lost now the retraction. It's a big disc. It's easier to feel than to see, but it's a big disc. Okay. Keep it like this. Bilateral up to 20. Yeah. Perfect. No, it's fine. Knife or what do you have? Scissors? What do you have? There usually is a scissors with it, but I think they might not be available. No scissors? Okay, then give me a long knife. This is not working. This one. This is the knife holder. This. So we have to be a little careful. So the scissors are not there anymore. Oh, this big knife. Oh, you see the size of the. Oh, this is very big. Ay, ay, ay. Can you put it the other way around? Not possible, huh? Scissors are better. Any scissors are fine. This knife is very good. It's perfect. You see the size of this? These scissors, they don't belong to the set, so we have to do a little bit. Give me the knife again. Let's try with the knife. Try if you can do it the other way around. Yeah, perfect. This is perfect. Now you see the disc prolapse already coming up. Yeah. The hook, I like the hook. Okay, give me the pituitary. Better we take this out. It's too small. Okay. Let's try what's the finding which compressed the nerve root. We will try and take a little bit more. Then we need irrigation with a long tube to irrigate the disc. Okay, so hook. No. Okay. Last thing again, get that. How severe is her radicular pain? Okay. Maybe can you get some triamcinolone? Yes. We can just put it in.
I think my was right. Right.
You see now nicely the pulsations. It's much better. You see the pulsations of the thecal sac. You see what is moving. With each CSF pulsation, you see the thecal sac is moving. Okay. Okay. The long hook. Good. Very good. All this along the nerve root. Good. Let's do the irrigation. I now irrigate the disc space. It's good. It's good. Picture there again. The hook again. Anyhow. So the hook might be 4 or 5 millimeters. So this is the opening. It's maybe 3 millimeters in bright width, and length is maybe 7 millimeters. Okay, so in this case, she has 7 out of 10 pain. So we put in some triamcinolone. What is it? Maybe in gel form. And we're done with the case. Any questions?
Yes, we have questions. Just a moment. So I would like to question that while you're doing this procedure, and when you just get into the spine, if the ligamentum flavum that is quite thickened and at the same time very adherent to the spine, then what are you going to do for that? That's the first thing. And secondly, while doing the procedure, if a ligamentum flavum is quite thickened and while removing it, we clear this thecal sac. So then what will be your procedure regarding that? I would like to know.
So the first question, when the ligament is very adhesive at the dura, is that right?
Yes.
Well, I always do it like this. It's more difficult in recurrences. In recurrences, we do it sharp dissection. For example, if we have a synovial cyst, we do blunt dissection, because in recurrence, I think it's so adherent that I cannot clear it. Yeah, in the recurrence, I do sub-dissection with the scissors. This is our J fold, and this is we are done. But I basically do it always like this in multiple steps. But the steps, you need 2-3 steps, but it's just focus. It's just on one position, and that's it. Okay. You do one on the fascia, subcuticular, and subcutaneous, subcuticular. Okay.
There are more questions.
Yeah, go ahead. I come up. I come up. Oh, give me a scale. You have a scale, a measure bend. Last thing, I just show you the size of the diameter of the skin incision. Okay, give it to me. It's fine. I take it. Give me. Yes, sir. Another question. What was the second part of the question? I did not get that.
Yeah, give us a moment.
When the dura opens or if it adheres?
Basically, I was talking about in the meanwhile, the dura, the ligament of phloem is quite adherent to the fecal sac, and while removing it, you just tear the dura. So, what you will do procedure regarding that?
You have to open it up sharp. So, this is the skin incision. Where is it? You see that? 1 point, maybe 1.8, 1.678 millimeters, centimeters. Okay. So the dura, if you have to clear it, then you need a small kerosene punch or the scissors, micro scissors. Maybe you have 1 minute and I'm with you. It's better because the audio is much better, but it's not perfect.
Okay, then
I'll be with you in a minute.
We can see the meter where it goes, but where exactly the tubular sector is placed. So structure is bigger size. So this is the smaller one in the middle, and then the structure which goes into and then final goes the final structure is 3 final size. So the structure is exactly related with the structural division. The structure comes down like that onto the lower end. You will become like that. With the bone side, the L4 side, you stay straight. So that's how. Let's say you cannot dive it, but you can.
By the way, your know that position the folder on the same place as the check. Normally it's one surgeon section, so you don't need systems and it's no place. That's why you by the positioning folder is dealing on the opposite side. So you're standing on the side of the herniation and in case you encounter I would say that after advanced like that, 50 cases, you have one consistently for 7 to 2. So it's 3 to 5% maximum. Normally 1 to 2%. So I'm doing via the same approach and with the microscope because it's not convenient to manipulate. Change the tube to that far, or just put the glue. But normally and you get especially over the paramedian this and when you go for center well, one word before common congratulations. I think I just frustrated. I think I'm supposed to everything was prepared. There was nothing to although I looked for it. Are there any questions? Are you all ready for that? You saw the training? Very nice. Now, midline is produced concern.
sometimes but it's just midline, and in the center, I would review on the top of the Well, then you get some more photos, a little more photos, and you go a little more. Okay, what time is it? Are we in time or are we? What do we do after that? Yeah, delivered by the best. No, let's do it here. 145. 145 here, and then Dr. Zipper is done his thesis on genetics of glioblastoma. And this is the brand new research, and I think it's a good idea maybe for early detection. To do it because I think it's really interesting. Talk and then Cadaver.